Okay, perfect. Thank you everybody for coming back and for continuing our lecture series. Today, we're going to be talking about cognition, depression, and dementia. And what's going to be interesting about today is that we're going to talk about these three different entities as individual, as well as the tremendous amount of overlap and how it could be confusing, and hopefully help you sort through it. Last time we met, we tried to hit the high points, the highlights of normal aging. And the goal of that, my goal, was so that you would have a little bit of insight as to what's normal aging, and you won't think of it as pathological and worrisome. And the flip side, if something is not normal aging, then you just don't say, oh, poo-poo, it's because you're older, but to have it properly addressed and treated. And that's kind of the same theme I'm going through today with the cognition, depression, and dementia, is to walk through a patient who comes to me saying they have memory loss, and for me to tease out whether this memory loss is truly a cognitive deficit, and if so, which one, and if not, then what could it be? Is it a depression that's appearing as a pseudo dementia? Is it um, a there's a whole host, and we're going to go through all of them. So there's quite a bit of differential when someone comes through, and I think the quickest and easiest way is to act as if you're with me in my office, and for you to pretty much enter my brain and see how I work through this. And you can use this whether it's, Kayla working through for the assisted livings, and or if you even do some work in long-term care, even private care, whatnot. So on a professional level, it can be for those who are residents, to use this technique for your friends, your families, and whatnot. So it's just not a doctor technique. It's just a comprehensive way of looking at it. So we'll go ahead and get started. So when someone comes to me and asks for help for cognitive deficits, there's typically two groups of individuals. There's the individual who's self-directed. So this is usually the 50, 60-year-old professional who comes to me and says, Dr. Varano, I need help. I feel that my memory is slipping, and I don't want my profession or my personal life to suffer as a result from it. Please help me. That's one group. The other group is a family, either a husband, wife, or child, who brings their loved one and says, Dr. Varano, my mom or dad have presenting symptoms that I think are consistent with dementia. Can you please confirm that? And those are two completely different pathways. And when I hear that, I'm thinking already, before I even interview them, different diagnoses. So, but they're addressed the same. So for both of them, I would say, so for the person whose self-initiative is to come in and say, hey, help me, I would flat out ask, please give me specific examples of how you feel that you're cognitively impaired, and why it's so worrisome to you to come seek my evaluation. And then for the family, I would turn around and say, please give me specific instances, not just they're losing their mind or these vague terms, but I need exact examples of situations in which their mom or dad or loved one behaved concerning. or if it's a financial document, or what was it that encouraged you to call me and ask for my help. So that's important too. So now we're going to go down each pathway. So we're going to be kind of flipping back and forth between different types of scenarios so that you can see all of them. So for example, for the gentleman who says, or the woman who says, I'm a professional and I can't afford to have any decline in my cognition, it's a liability. And I say, okay, please explain to me what happened. And they explain that they went to a wedding and it was their son's wedding or grandson's wedding. And let's make it the grandson's wedding or son's wedding. And they simply couldn't remember the name of the bride. And the bride's name is Mary. And they go on to explain to me in great detail the wedding, the cost of the wedding, the location of the wedding, and how not remembering the name of Mary destroyed the entire night, how it caused conflict between the significant other, and all this. I just let them talk, but by the end of that one example, I am pretty confident that what they're experiencing is normal biology of aging, simply because they spent 5 minutes giving me detail of the event, and they had all recall of every single part of the event and the emotions attached to it, and so on and so forth. So that person, initially in my mind, I would categorize as normal biology of aging. However, with that being said, there could be a component of mild cognitive impairment. So I would absolutely share my thoughts and say, because you remembered it and because you presented it in this fashion, it's my belief that you have normal biology of aging, but let's go ahead and do a mini mental on you. And I encourage everyone on this call who's not familiar with the mini mental to just take a look at it. It's been around for the longest of time, and many institutions, Yale and others, have tried to create tools, cognitive screening tools that have higher sensitivity and specificity than the mini mental. But the mini mental has a very high inter-rater reliability, which means if I do the mini mental and someone at one of the assisted livings does the mini mental, our scores should be pretty consistent. The difference between a trained professional doing it versus someone who's not trained is the trained professional can read through the personality and the approach to the test taking that is not objective. That's the subjectivity to it. So, the art and science of medicine, that's the art, not necessarily the numbers that come out of the mini mental. But I do encourage everyone to look at it. It comes in every possible language, and you can print it out and you can do it on your loved one. You can do it obviously on patients, and it's something that I do routinely on all my patients. I do a mini mental and a geriatric depression screen. So for this gentleman, let's make him a gentleman, who complained about the loss of memory during the wedding, if I did a mini mental on him, and let's say he was a lawyer or a nurse or an executive, he should absolutely get a 30 out of 30 on his mini mental. If he got anything less than a 30 out of 30, then I would really reflect on how he answered the questions. And what's important is, and when we get into more detail about depression, is those who are depressed will say they can't answer it, and they actually do. And those who have Alzheimer's might refuse to continue taking the exam because they have, in the early stages, insight that they have deficits. So I would probably reflect on how he answered the questions, whether he was defensive, whether he was annoyed, and where was the deficit? Was the deficit in recall? It's a 3-item recall. If so, then that's very, very concerning. If the deficit was on the date, but yet he was on vacation for 2 weeks, that's less of a concern to me, okay? And then we'll work up mild cognitive impairment, which is subjectively, an adult is complaining of cognitive deficits. Objectively, we can support the cognitive deficits, but they're not so severe that they fall into the category of any of the dementias. So this individual, we would watch and repeat the mini mental periodically and encourage them to live a healthy lifestyle and decrease inflammation, because if they are prone to a poor lifestyle, we're learning that unfortunately with Alzheimer's, we are seeing that. So we want to have a healthy mind with a healthy body. So that would be that kind of case scenario. Now, the other case scenario would be them coming in and the family saying that a loved one is not the same way they used to be. They have the family's thinking dementia. So I would say I need to know specific examples. Give me multiple examples of why you're making this this assumption. And if they say, well, they forgot to pay their bills, or they forgot so-and-so's birthday, or they forgot a name. Those are vague symptoms that, sure, that could be consistent with dementia, but that also could be consistent with depression and anxiety and a whole host of other psychosocial issues. So what I would want to do is go down all those differentials. And Alzheimer's disease has been around since 1905. I'm very surprised that in 2021, we still don't have we don't have treatment. We don't have treatment for the disease. We don't have medications to prevent the disease. But there is a huge race to the end, and everybody, all these pharmaceutical companies are looking at that carrot at the end, because that's a multi-billion-dollar industry, in my opinion. So whoever comes up with a cure is set for many, many generations. So that's the good news, is that we do see a lot of clinical trials that are in phase 2, phase 3. Some of them are getting positive results. Some of them are getting mixed results, but those mixed results, I'm hopeful, will be sorted out. And I'm thinking that we might get this disease under control. But for the present day, I would have to differentiate what's going on in this person. So the first thing I would say is, once they give me a concrete example, and if it doesn't 100% convince me that I should jump into a mini mental right then and there, I'm going to ask a little bit more detail. And I'm going to try to rule out pseudo dementias. So a lot of disease states can present as if the individual has dementia when they really don't. And we all know of the reversible dementias like vitamin B12 deficiency and thyroid deficiency, metabolic syndromes, and so on. And sure, I would draw blood to rule all that out. But while you're in my office, I'm going to ask questions. And the first and foremost, and we have a lecture on it April 16th, and I think that's session 5. I think that's one of the most important lectures out of the series. And I'm going to give you a little preview today because it obviously ties into our discussion of cognition, depression, and dementia, and that's sleep. So I always ask my patients, tell me about your sleep. How much do you sleep? What time do you go to sleep? Do you have difficulty falling asleep? Do you have difficulty staying asleep? Do you have early morning awakening? And I ask for a diary. I want to know all the details surrounding your sleep hygiene. And the reason why I'm so strict about that is because sleep deprivation is very well known to cause the individual the following day to have a foggy-like mental state and all the signs and symptoms consistent with dementia. And I've had many patients from other physicians diagnosed with Alzheimer's disease, put on medications, and come to me, and they don't have Alzheimer's disease, they have insomnia. So that's why I'm pretty strict with my diaries. And during this lecture, if there's nothing else you take home, one of the key points, and definitely for, Art and Donna, who've been to every one of my lectures so far, I absolutely encourage both of you to have diaries of pretty much everything that's going on, because timelines are critical. So when I ask about these instances, before I even go on to sleep, I say, how long has this been going on? And sometimes my families remember it and sometimes they don't. They usually remember it when it is associated with a function, a wedding, a funeral, a religious holiday, something where they identify that their loved one was behaving differently. So absolutely keeping a log of what's going on in your health, with your doctor's appointments, how you see your loved ones around the house behaving, is very valuable when you go to the doctor and they say, how long have these memory lapses been going on? You could say, by looking at your log, oh, I can't believe it's already been 5 years. It feels like yesterday, but it really has been 5 years. And that helps the physician go down the proper diagnostic road. So when I ask for sleep, and I ask, are you having a hard time falling asleep, staying asleep, early morning awakening? That's important because difficulty falling asleep, some people have anxiety disorders, and that brings me down one path. Staying asleep, why are you having a hard time staying asleep? Fragmented sleep absolutely can have daytime consequences. And very clearly, daytime consequences are fatigue, lower pain threshold, so they can go to their doctor and ask for an increase in pain medications when it's almost artificial. The reason why they have more pain is not because they have degeneration of the nerves, if it's neuropathic pain or increased muscle spasms, if it's musculoskeletal pain. No, it's simply as a result of sleep deprivation and insomnia. So they could be unnecessarily increasing their pain medication. Longer reaction time. So if they're driving, we see increased accidents as a result of insomnia because it takes them a longer time to go from their foot from the brake to the gas to the brake and so on. And we do see increased accidents. Reduction in psychomotor performance. So they're slower. They're slower to answer your question. They're slower to respond intellectually. And if they have a job in which they have to, a trial lawyer or any of the medical fields or whatnot, and they have people questioning them and they have a delay in their response, that could certainly interfere with their work. And I've had, unfortunately, many patients that were fired because they weren't able to do the job the way they were years ago. Attention span is diminished. And of course, memory, the ability to recall, is diminished, all as a result of insomnia. And why is that? Because the first 4 hours of sleep are what is called restorative sleep. And that is where you get the biggest bang for your buck. And you do not, as soon as you put your head on the pillow, you do not want to wake up during those first 4 hours. If you sleep those first 4 hours and then you wake up, believe it or not, you have that restorative sleep and you should be okay the following day. When you're not okay is if you wake up, you fall asleep, you wake up after the second hour, the third hour, or anytime during those first 4 hours. That fragmented sleep is now very difficult to catch up. So restorative sleep is by far the most important part of any sleep. And I've had patients tell me, well, Dr. Varano, I've been in bed, I'm in bed 10 hours, or I'm in bed 8 hours, or I'm in bed 9 hours. It doesn't matter. If you don't have the first 4 hours solid, and you stay in bed 10 hours, it's very difficult to catch up unless you have that 4 straight hours. So I ask about that. And before I start pulling out my prescription pad and writing Aricept or doing a mini mental or any of that, if you're telling me that you have sleep disturbance, that's the road I'm going to go down. That's the trail. That is the problem that I'm going to try as best I can to resolve. Then the next problem is sensory deficits. I want to know, how is your hearing? How is your vision? How are all your senses? And the last time we were together, I gave you an example of the gentleman who couldn't hear. And as a result of him misunderstanding the conversation, he was labeled by others as either being crazy or having dementia, but he was deliberately left alone. And as a result of his isolation, he made the diagnosis that I forgot my shopping list at home. I'm 85. No one wants to be around me. Clearly, people are annoyed with me. I must have Alzheimer's. And as a result of him making this self-diagnosis, he withdrew because he didn't want anyone else to see his deficits. And he slipped into a major depression. And the interesting situation is that he did not have Alzheimer's disease. And those individuals who have untreated major depressive disorder are at higher risk of getting Alzheimer's disease. So isn't that criminal that you have a gentleman who has hearing deficits? He convinced himself he has Alzheimer's disease. He gets very depressed about it because as of today, there is no treatment plan. He goes into a depression, and if it's untreated, he will either be diagnosed as having Alzheimer's disease, because moderate Alzheimer's disease, their symptoms are very similar to those who have major depression. And unless someone brings him to the physician to sort out, does this individual have a major depressive disorder, or does this individual have Alzheimer's disease, he might just get diagnosed as Alzheimer's disease and might refuse to have treatment and might end up passing unnecessarily, or might end up having untreated depression for years and years and years, and then ultimately getting Alzheimer's disease. So it's very important to understand if there are sensory deficits and are they being addressed accordingly.
Dr. Varano.
Yes.
We have a couple questions.
Sure. Let me see if I can. Let me see if I could see all the.
I know we didn't do anything in the chat, but I have a question on the sleep deprivation.
Sure.
is, like I read something about melatonin. I mean, is that something that you would recommend, or is it, I mean, is it for real?
So, I mean, melatonin does work. Absolutely, it does. But the problem with me recommending melatonin is because when I have somebody who has insomnia, because as you can see, I value it so much, I have to know what's causing the sleep deprivation. And I'm on all my lectures, you will hear the same thing over and over again. I'm an individual who focuses on root cause. So I always do a root cause analysis of why we are where we are today. And I use that not only in medicine, I use that for finances, I use that for my children. I use that psychosocially. I use that on every aspect of my personal and professional life because it's critical. And the reason why, I'm going to give you examples. So if somebody says they're having a hard time falling asleep, and I ask them, please share with me what's going on. And they say, my mind is racing. I can't stop it. I can't slow it down. And after further testing and evaluation, I find out that they have an anxiety disorder, or they might not fulfill all the criteria for a true generalized anxiety disorder, but they do have anxiety. If I give that person who has anxiety a sedative hypnotic, I give them Ambien, and I put them to sleep, I did not treat the underlying disorder. So they still have anxiety. So once they wake up after the medication has worn off, they still have that anxiety and they did not have a restful night. They are trashing and they're having nightmares. They're still anxious. I never turned that off. So I just masked what it was and gave them a sedative hypnotic. If they're not sleeping because they're having what's called Nocturia, which is they waking up in the middle of the night to void, that is very disruptive. And that does not respond to behavioral modification. That's a medical diagnosis with medical treatment. If they're waking up in the middle of the night to void as a result of medications, Lasix or any other diuretics, or because they drank a lot of water before they went to bed, well, then behavioral modifications for that works like a charm. So to answer your question, melatonin does work. I would recommend it if you do have insomnia, only after you've ruled out all the other possibilities. Lots of times, there's sleep apnea for the individual, or their sleep partner is having sleep apnea and that's causing them difficulty sleeping. Sometimes it's restless leg syndrome. So there's a whole host of reasons why we don't sleep well. But if we rule everything else out, absolutely, I'm okay with melatonin. Sorry, that was a long answer, but.
I have to do with anesthesia.
And I heard there were some other questions. Were there any other questions?
Larry's being shy.
No, I have a question. I don't know if it relates to what you're talking about, but can anesthesia have an effect on memory loss if someone has a long surgery for some unrelated issue, putting the brain to sleep? Does that have an effect on memory?
So the answer is yes, it could, as well as chemotherapy, as well as a whole host of other things. And one of the biggest concerns I have is medications in the elderly. And there is a list that I'm sure, the nurses in your facility are referring to. It's the Beers list. And that is a list that is routinely evaluated. I think the last one was 2019. And they list medications to avoid in the elderly, and they give the rationale behind it, whether it causes increased confusion or falls. And sometimes, if applicable, they will give you a substitute. So for medical legal purposes, I refer to it. And if I have to have somebody on a medication that's on the list that's not advisable, I document in my chart my rationale, my risk-benefit ratio as to why I picked that medication over others. So classic ones are for overactive bladder, the oxybutanins, those types of medications have been, it's interesting because the medications we give for Alzheimer's disease is anticholinergics. And the medications, we use for overactive bladder or various other neurological disorders are cholinergic. So, on one hand, we're trying to increase a chemical, and on the other hand, we're trying to decrease a chemical. So, so reviewing the medications is critical, and there are alternatives for overactive bladder. There's I actually just finished a clinical trial, and it was approved in December for a beta-3 agonist called Vibegron, which is not going to affect your memory. It's not out on the market yet. It's going to come out probably April or May. But medications, Larry, anesthesia, those on the Beers list, all those can absolutely contribute to temporary memory loss or permanent. And as I was writing articles, and I'd be more than happy to share any of the publications with anyone who's interested, as I was writing articles for urological journals, specifically for the older adult, it's been proven that a lot of these medications for overactive bladder have had permanent cognitive deficits. And so here you have individuals who are urinary incontinent, or if they have wet overactive bladder or dry overactive bladder, but they are having these urological issues that they're requesting medications, and it's been proven that they have cognitive deficits. So one of the biggest things I look at when someone comes with memory loss is the medication list. Absolutely.
Well, there may be a substitute for overactive bladder medications, but there may not be a substitute for anesthesia, obviously, if you need.
Absolutely. Right. Absolutely. And the difference is not everybody who receives anesthesia has cognitive deficits, but a lot of people who have overactive bladder and receive medications to get cognitive deficits. So that's a difference. So yes, it does happen with anesthesia, but it's not on a prohibited list, shall we say. But yes, it can happen. And especially the longer the surgery, the greater the chances. So any other questions before we?
Could you tell me the name of that test that you're talking about? You keep saying it sounds like Maine mental test.
Yep.
Is
So,
it Maine?
So Donna, it's called MINI, MINI dash.
MANI. Okay.
Yep. MINI dash mental, MENTAL.
Got that. MANI. Okay. Dash.
MINI mental, and then it's called state, STATE exam. And the abbreviation, Donna, that a lot of physicians will say, and you might have even had one, someone might have even done it on you, maybe a primary care, just as a matter of, one of our geriatric vital signs, they might have already done it. The abbreviation is MMSE.
MMS.
Like in SAM or state.
Okay. Oh,
So
okay.
MMSE stands M for mini, M for mental, S for state, E for exam.
Okay.
And you could Google it and you'll see it. It's 30 questions. It looks almost insulting when you answer the questions if you're cognitively intact. But if you're not, it's definitely a challenge. So, and what's fascinating about it is, and I don't know if I'm able to share my screen or not, because I do have one, but I don't think I'll be able to. I don't know how to share my screen. I don't want to mess it up. But I do have it on my slide deck, which is on my desktop, opened in case anyone had any questions, but I'm afraid that if I share it, I might mess it up. But anyway, if you do Google it, you will see it in every possible language. And what's fascinating about it is it really evaluates various domains of your brain. So it evaluates recall. So it'll ask you to remember, say, 3 unrelated items like book, house, candle. And then you do a couple other questions, and then they ask you to say, what are those 3 items I asked you to remember? And so it's a delay. So recall is by far the most important part of the MMSE. That to me is the most valuable because that's the first thing that goes when there's cognitive deficits. Then they evaluate other parts, like I said, other domains. They evaluate language. They ask you to say no ifs, ands, or buts. They ask you to write a sentence. And with the sentence is very valuable because if the person is writing very, very small and you see micrographia, it might bring you down a road of, does this person have Parkinson's or other neurological disorders? They ask you for attention, and attention will help rule out delirium. So one of the attention components is asking you to spell the word world backwards. And I always say spell it forward so that I know the person I'm speaking to can spell forward. And then the reason why they're asking you to spell backwards, not that they care how you're spelling. The goal is, can you sustain attention for 5 digits? And if you cannot, and you get distracted, then that brings the physician down a pathway of delirium, which is an acute confusional state, which occurs very on a daily basis in our seniors. And I'm sure in the assisted livings, you see it every single day. So if a senior is fine today, like you are, Donna, and then Art notices that you're confused tomorrow, the nurse is going to get a urine sample immediately to see if you have a urinary tract infection, if you're a uroseptic, because that's the #1 offender for delirium, which is the acute confusional state. That's reversible if diagnosed. And if not diagnosed, surprisingly enough, people can walk around with a delirium, and they will just be labeled having dementia. But in reality, they have an acute confusional state that is most often related to infection, something offending the body. And this mini mental, when I ask somebody to spell world backwards, if they can't do it and I go down that delirium pathway, I very well may reveal that this person had a delirium. Now, for the nurses who are listening to me, they might say, well, Dr. Varano, it doesn't make sense because a delirium person is, in their mind, they might be thinking someone who's hyperactive. And what's fascinating about delirium is, you're right, there is a hyperactive cohort. However, in delirium, it comes in 3 forms. Hyperactive, which is the wild person that can't hold a conversation. They're all over the place. They almost look manic. There's the normal active, which looks like you and I. And then there's the hypoactive, who looks as if they have a major depression. So delirium does come in 3 forms. And with that component of the mini mental, we can identify it. If they say, I can't spell world forward, that's okay. You just ask them to subtract 7 from 100, and they do that 5 times. So it has to be 100 minus 7 is 93, and then 93 minus 7, and you just keep going 5 times. And once again, it's not for mathematical skills, it's for your ability to see how they can sustain that attention. So it's really easy, and you can do it on your significant other, or your children can do it on whoever they're interested in. So that's it for the mini mental. Now, Donna, there's a thing that some physicians do, and I call it a thing because it's not really a full diagnostic, but a lot of physicians say, I simply don't have 15 minutes to do a mini mental. I just don't. Dr. Varano, give me something that I can do as a screen for dementia. And that is called a mini cog. So same thing, MINI, and then it's -COG. And the mini cog is very, very simple. It's a 3-item recall. So you take that recall component of the mini mental and you say, okay, I'd like you to remember 3 items: book, house, candle. And you ask the person to repeat it because you want to make sure that they hear what you're saying. Sometimes there's what's called a receptive aphasia, an expressive aphasia. You don't want to have any of that. You just want them to say, okay, Dr. Varano, book, house, candle. Fine. Then you have them draw a clock to waste time. Okay. And you tell them, because you have to have a delay. So you tell them, here's a piece of paper. Now, some physicians have a circle already pre-populated on the sheet. I don't. I just give them a blank piece of paper and I say, please draw a clock and draw it where the time is 10 minutes to 2. I watch them. I watch, are they making the clock where the circle, the 2 ends of the circle reach each other, or is the clock like a U? Do they have higher executive function, which means do they plan, sequence, and execute this event? So do they do 12, 6, 3, 9? Do they evenly distribute the numbers and then put them in? So it's all planned out and neat. Are the hands placed properly? Okay. And after they complete this clock drawing test, I then say, so tell me, what are the 3 items I asked you to remember? If they remember all 3, then you can comfortably say that dementia is ruled out. If they don't remember any of the 3, then they need the full mini mental. If they remember 1 or 2, then you look at the clock drawing test. Is the clock drawing test perfect? Then you can say, we're going to go on the no dementia camp. If the clock drawing test is off, meaning rather than doing the numbers of 1 through 12, they actually write numbers, or they don't make a circle, or there are no arms on the clock. And you say, does this look complete to you? And they say, yes, it does. So as long as they don't have any visual problems or arthritic problems or any physical interference, and the clock is not in good shape, then you can definitely say that they have to go down that cognitive full workup, which would include the blood draws of the B12, the folate, the thyroid, diabetes panels, and so on. And then of course the mini mental. So, I'm sorry?
The drug test, was it DeBeers, DeBeers?
Nope, Beers, Beers. And I'm gonna see if I could pull up the full name for you, but it's, yeah, if you Google, and I'm gonna do it right now so that I have it in front of me. So Beers criteria, that's all you have to put in and it will pop up. And it's B like in boy, E like in Edward, E like in Edward, R like in Robert, S like in Sam. So Beers criteria. And the American Geriatric Society is responsible for updating it. And as I said, I believe 2019 was the latest update. And it's very comprehensive, and your physician is probably very familiar with it. But I just went on my phone and I put it in and it pops right up. Drugs pop up and whatnot. So to get the full Beers listing, I think there is a cost to it, but you don't need the full listing. You just need, certain whatever issues you're looking for, and it's usually cross-referenced. So if you put urinary incontinence and Beers, you're going to see 1,000 articles. So you don't necessarily have to buy the full Beers listing. I mean, if you want to, you could. My understanding was that it was something that one had to purchase, but I never purchased it because it's always cross-referenced. So it's easy, okay? Any other questions before I go on?
Thank you.
No, you're welcome. Okay. So after we evaluate whether sleep is okay, whether sensory deficits are okay, the last part that I evaluate before, and this is all before I go into formal testing, is psychosocial situation. Depression is extraordinarily common in the elderly, and not surprisingly. They will, they have lost independence. Some of them have lost financial independence. Some of them have lost loved ones. It's very devastating if you're an older adult and you have to bury your son or your daughter or your granddaughter. Sometimes it's very difficult to get back from that event. So losing independence, losing strength, losing the ability to control. So we talked about urinary incontinence before, and on April 30th, we're going to give a whole lecture. I'm going to give a whole lecture on urology and talking about all the different types of incontinences and how it absolutely affects one's life. But you can understand why an older adult would be depressed. They can't see, they can't hear, they can't taste, they can't walk the way they used to. Every body part hurts, diminished strength, diminished ability to recall in normal settings. So there's a lot going on. And then a lot of older adults have not planned to live to be 95 or 98 or 100. And so their robust retirement plan is not so robust. And because a lot of individuals have money in the stock market, unless somebody's monitoring that 401k and it's not, unless it's age-based or a target date fund, if you just put that money in when you were 20 and you put it in all equities and now you're 90 and the stock market crashes and you didn't look at it and you just pull out the money when, or your mutual funds or whatever it is, and you're having required minimum distribution and that's what you're getting, or dividends and that's what you're getting. But now the market crashes and now all of a sudden you wake up and you're like, oh my gosh, what just happened? That is devastating. A lot of my older adults get very anxious, depressed, and whatnot. So when I'm talking about cognition, and I'm talking about depression, and I'm talking about consequences of it, depression is real. And the older adults are very different than the younger ones. So 18-year-old who scratches their wrist and says, oh, woohoo, look at me, that person really doesn't want to kill themselves. That person is either seeking attention or starving for help me. Maybe they're getting abused. Maybe they are having issues and they don't know how to handle it. They don't know how to get help. So that's a cry for help or attention. And the younger adults who've committed suicide, some of them just do it and they're not really thinking through the consequences of their actions. So it's not uncommon to hear, well, so-and-so killed himself to spite his girlfriend, or to give it to his mom, or to show them. But they're gone. And they don't necessarily, in that state of mind, think through that. The older adult's different. The older adult is very systematic in what they're thinking, and they do a risk-benefit ratio, and they realize that this quality of life is not for them. They're depressed. No one's talking to them. No one's talking with them. No one's listening to them. They go to the doctors. They're always being rushed. They're in pain. Pain is not being managed. Depression's not being managed. The quality of life is zero. Their finance is zero. severe depression sets in, and successful suicide amongst the elderly is very, very high. They're not looking for attention. They're not looking for help. They're looking to end their life. So very violent ways of ending their life. They either hang themselves or shoot themselves with guns. So one of my screens when I deal with my elderly is not only the mini mental, not only the geriatric depression screen, because everyone gets a screen from me on my first encounter. They do not leave that room unless I see it, what their geriatric depression screen is like. And it's a 15-point. There's a 15-point screen and a 30-point screen. And Donna, you can look up that too. It's called Geriatric Depression Screen, and the abbreviations is GDS. And you're going to want the short form because it's only 15 questions. And when you read the questions, you'll say, oh, Dr. Varano, come on. These questions, they'll make anyone depressed. And that's not true. So when it's been a validated screen, and if you're depressed and you answer honestly, that could save someone's life. And if you're not depressed, then you'll be the one who says, oh, this is ridiculous, which is fine too. But it's a validated screen that I use on a daily basis. And, I recommend everyone doing it. So depression is very, very common. And as I said, suicide with hanging and shooting is extremely successful. So depression in the elderly is very important. So we want to differentiate whether the person who's in front of me is depressed. And if they say I am depressed and I'm on medications, well, let's do a geriatric depression screen on you. And if you screen high, so it's a 0 to 15 scale, and you get points for things that indicate that you're depressed. If you get 5 or above, it's an indication that you might have some depression. The higher the score, the greater the chance. And once you start getting to 11, I start to ask about suicidal thoughts and if you have a plan. And so understanding that this person has depression and is on medications, but is not adequately treated, that's critical. That's something that we need to address. If the person is depressed because they think they have dementia, then I have to do that mini mental on them. And when I try to do the mini mental on them, they'll be saying, my memory's shot. I can't do it. I'm telling you, doc, I'm gone. I can't do it. And it takes a tremendous amount of encouragement, but they do it. They can do the recall. They can do the serial 7s, which is that answering those, subtractions backwards. They can do the intersecting pentagons, which is diagramming. They can do the entire test. So once they finish it, I put it up to them and I say, you got a 30 out of 30. There's no way that you have Alzheimer's disease. And it really is pretty shocking to them, because they'll argue with me. The test is wrong. How's the test wrong? You answered it. I didn't answer it. So it's really an amazing tool and way in which we can help individuals. So the last component I look at, as I said, is the psychosocial situation. Is this person anxious? Because if anyone who's watching me now, if you can imagine yourself in a situation in which you are really, really anxious, you don't even remember your name. You don't even remember your phone number. You're so shooken up, okay? And so imagine that one instant that you had. People who have generalized anxiety disorder have that all the time, that frazzled feeling. So how can they think clearly? So that needs to be addressed before we go down the road and say, oh, they have Alzheimer's disease. So generalized anxiety disorder, major depressive disorder, minor depressive disorder, dysthymia, which is a very low-grade depression, all those need to be screened out before we jump and say, Mr. Smith has Alzheimer's disease and here's a pill. So as we're concluding our time together, now I could stay as late as you guys want, but I want to be respectful of your time. as we're concluding our time together, I just encourage you to do a diary for yourself, for your loved ones. And if you do have cognitive concerns, when you go to your physician, don't allow him or her to pull out a script and write a prescription for Aricept. You don't want that diagnosis on your medical history. Getting it off is going to be a challenge beyond a challenge, and I don't even know if you could get it off. So before you accept the Aricept script, say you want a full evaluation, which would include laboratory work, a geriatric depression scale, a mini mental. And if you're extremely intelligent, or if you have a very high education level and you get a 30 out of 30, then that's not appropriate for you. You need to go for neuropsych testing, in which they will spend hours evaluating the various domains of your brain, simply because you are too intelligent, or you are highly educated.
Dr. Varano.
Yes.
Another question. What's the deal with this Prevagen? You see all these commercials.
I do.
All geniuses, like all of a sudden, I don't understand if that's like, is it for real?
I do see the commercials. I see the same ones you see. I hear it on even like, CNBC and, all these, I do hear it. I'm the type of person who says, I get also asked about different vitamins and, vitamin E, and some people call it ginkgo biloba or ginkgo biloba, depending on who pronounces it. My suggestion is, I don't think it's going to hurt you. I can't guarantee you it's going to help you. I'm putting all my eggs in Big Pharma, because they know that the second they get an FDA approved medication to treat Alzheimer's disease, their stock is going to go from, a penny stock to thousands of dollars. So I'm putting my hopes in Big Pharma and the FDA for really giving us a high quality, reproducible study that, has statistical analysis. So to answer your question, if you wanted to take it, would I tell you don't? No, I wouldn't say don't take it. But if you take it and you don't get any results, I wouldn't be upset if you didn't get any results. I would be upset if you took an FDA approved medication and it shows, 90% efficacy in slowing it down and yours didn't slow down. That would get me upset. But, these over-the-counter types of drugs, I'm not too, I'm not going to say not to take it, but I'm not going to say to take it. Any other questions?
Anything there?
Dr. Varano.
Yes.
Hi, this is Diana. And my question is, do you record your sessions? Because I have a sister that would like to hear you and she wants me to take notes, but you give so much information. I don't know if I get it all, but I could listen to you all day. I just wonder if you have YouTubes or anything.
So Diana, thank you for asking that question. If you look on the upper left-hand side of the screen, they are recording it. So all the sessions that I'm doing in this seminar series, and I did one, I don't know if you were in the March 5th, What is Normal Aging one? That was recorded. Today's is recorded. And I also did a couple other with Arrow on the COVID-19, because I'm principal investigator for the Pfizer's clinical trial. And there was a lot of questions on, the virus and the vaccine and so on and so forth. And all those are definitely on YouTube. I don't know if they're posting these on YouTube. Larry, do you know if it's on YouTube or if it's just a
No.
link that's going out?
We'll find out.
Yeah, Kaylin just chatted that she can send it to the emails, the recordings.
Okay. But Diana, all the other sessions that I did, and I also did one for Arrow on blue zones, which is really good too. Those are all on YouTube. So just put in my name. It's Susan with 2 N's, SUSANN Varano, MD, and YouTube, and it should pop up with pretty much everything I've done with Arrow. And you might find also I've done on Euro Today, an interview on Nocturia. I know I had touched a little bit about Nocturia, and I'll bring that up once again during my urology session. But if you Google Euro Today, I did that. And then a lot of the stuff that I talk about on these sessions, I was interviewed by US News and World Report. So you can certainly put that in, and they have a bunch of articles on various geriatric syndromes, MSN and so on. So yeah, just put my name in there and I think things will pop up. But YouTube, I know for sure because I was looking at those when they shared it with me. Any other questions from anybody? Kayla, do you have any?
Not that I can think of.
Okay. And you're recording, right?
Yes. Yep. I was going to say, I did put in the chat. So if anybody wants me to send it to them specifically, you can leave your email here in the chat and I can send it to you. And I'll check with Kayla to see what the status of getting it on YouTube is. I think they were trying to create like a playlist to put all of the recordings to. So I'll check in on that.
Okay, sounds good. And if we're going to have a consistent group, and anyone has questions from, because we have 8 sessions, and we have the opportunity to answer. I have the opportunity to answer your questions. So if anyone here thinks of a question between now and our next session, which is April 2nd, and that will be on mobility in the elderly. If anyone has questions, certainly let me know in advance. And this way I will have it prepared for you. And before we start the next lecture, I can address your questions.
How did you say we would send the question to you?
I didn't. So you're absolutely right, Donna. Let's see, how can we get those questions to me? Mark usually, I don't know if Larry, you wanna, no, Mark just stepped out.
Well, I was going to say, I mean, if people, I can put my email address in the chat, and if anybody wants to send me any questions or comments that you have ahead of time, I can always field them that way.
Yeah, and if you send them to me, I don't want to put my email, and the reason why I don't is because I get hundreds of emails, and because I teach at Sacred Heart and University of Bridgeport, the kids are constantly emailing me, and it's just, you're just going to get lost. So if I get one email and I see it's from Arrow, or if I see it's from Omni, or if I see it's from someone that I'm familiar with, I will definitely open it. And if you could just put in the subject line, questions from lecture or whatnot, I will definitely open it and address it in a timely fashion.
Yep, I went ahead and put my email in the chat. So, and I can always send those to Kayla, since she's kind of more of the point person for this, and get those, passed on before your next program. So.
Okay, I'm just reading the chat here.
And Diana, I'm copying your email so that I can send that to you as well, send the recording.
Okay, thank you so much. And I think last time someone asked a question about if you had any, I think,
Resources.
yes.
Right. So, yes. So I've been researching resources, and I didn't want to bring it up because I don't have a list, but I did find, because what I'm trying to do is find two ways of you learning. One is a podcast and one is reading. So for those of you who have, let's say, macular degeneration or something along those lines in which reading is a challenge, I'm trying to minimize that. So there is I did find one physician who's very similar to me in her approach and very similar to me in her lecture style. She's casual, but she has content. And this one is very good because she has a podcast for those who are visually impaired. She has a written version of it, and she comes out periodically. So she has her own newsletter and so on and so forth. Okay. Let me see if I should put it in the chat, or I could just tell you. I could just tell you what it is. So I have it on my screen because I pulled it up for you. So it's called Better Health While Aging. And her name is Leslie. And her last name is Kernin, and she's an MD. And when you put it in your podcast, this is what it's going to look like. That's what she looks like. So if you want to take a screenshot of it. So she's excellent. She addresses all the geriatric syndromes. She addresses COVID. She addresses pretty much everything that I would address. So of all the resources that I've evaluated, I think this would be most valuable to this group.
Thank you so much.
You're welcome. Any other questions or concerns? And I thank you for bringing that up. As I said, I was hesitant to do it because I was hopeful to have more than one, but I'm so grateful that you brought that up because at least this gives you a start. And there's so much material in there. She goes back years and years and years, so you can watch or listen to podcasts from 2018, and there's quite a bit, so you'll learn a lot. Okay. I think we're done, and I see that someone had posted a YouTube. This is the link for the March 6th program. I don't know if everyone sees that in the chat.
I'll still send it out in the email for those of you that sent me your emails. So.
Okay, perfect. Well, thank you, everyone. Thank you for coming, and I look forward to seeing you next time.
Thank you so much. We'll see you next time.
You're welcome. Take care. Bye-bye.
Bye.